Welcome back to the deep dive. Okay, today we are clearing the decks.
We are.
No general trivia, no, light reading. We have a very specific, very high-stakes mission.
I like the sound of that.
On the desk in front of me, I've got the heavy artillery. I'm talking Miller's Anesthesia 10th edition, the Objective Anesthesia Review from Tata Memorial, Kaushik Jothanath's Anesthesia Review, and this massive binder of past DNB and Gujarat University question papers.
Heavy artillery is exactly the right word for it. I mean, that's the survival kit for any postgraduate trainee right there.
It really is.
And we're not just browsing topics today. We're doing a deep surgical strike into one of the, I think, most feared areas of the entire syllabus.
That's right. We're simulating a final exam prep session. I am, for today, stepping into the shoes of the postgraduate student, let's say a second or third year resident, who is about to face the firing squad. And you?
I'm stepping into the role of your senior faculty. I'm the external examiner. I'm the one sitting across the Viva table with a cup of, lukewarm tea and a pretty stern expression, just waiting to see if you're safe.
Safe to be let loose on the pediatric population.
Exactly. My job isn't just to teach you the facts, it's to drill you. It's to catch your mistakes before you make them for real and, show you how to frame that model answer. The one that gets you the pass or maybe even the gold medal.
I'm already sweating. Okay, so the topic on the chopping block today is fluid and blood management in children and pediatric daycare anesthesia. Why is this one the monster under the bed for so many examinees?
It's the monster because the margin for error is, well, it's effectively zero.
Zero.
Think about it. With an adult patient, if you're a bit sloppy, if you say overload them by 500 milliliters of saline, their kidneys will probably forgive you.
Right, they'll just pee it out.
They'll diurese it out, no big deal.
Yeah.
But if you make a simple math error in a neonate, if you're off by just 50 milliliters, you can push that tiny child into heart failure. You can dilute their sodium so fast that they seize. You can even cause an intracranial hemorrhage. The stakes are they're incredibly high.
So it's high stakes because the physiology is completely unforgiving.
That's it. And it's the ultimate trifecta for an examiner. It tests three things at once. One, your core understanding of physiology. Two, your ability to do rapid mental math under a ton of pressure. And three, your clinical safety judgment.
And that's why we see it everywhere.
It's everywhere. It's in the theory papers as a long question. It's in the clinical cases. You get a cleft lip or a congenital hernia, I guarantee you will be asked about fluids.
And the table viva.
Oh, it's a staple of the table viva, absolutely.
I've been looking at the exam framing from our sources, especially the DNB questions. And you're right, the frequency is just relentless. December 2007, fasting guidelines. December 2011, anesthetic implications of a 6-month-old. June 2013, biliary atresia.
And notice the specificity in those questions. They don't just say child. They say 6-month-old. They say 1-month-old. They want to know if you understand that a 1-month-old is physiologically a different species from a 6-month-old who is different again from a 6-year-old.
And that's the core theme Miller just keeps hammering home, isn't it? That phrase. Children are not just small adults.
Precisely. Organ system maturation is a dynamic process. It's constantly changing. So our mission today is to build that model answer. We're going to deconstruct the physiology, the fluid calculations, the blood management, and the daycare protocols. I'm going to grill you, I'm going to set traps for you, and I'm going to make sure you know exactly what to say when that examiner looks over their glasses at you.
All right, I'm ready. Let's start where every Viva seems to begin. Part B, pediatric fluid physiology.
Okay, open your notebook to the page on body fluid compartments. This is, and I'm not exaggerating, exam gold.
Okay.
If you get these numbers wrong in the first minute of the Viva, the examiner, mentally they stop listening. They've already put you in a box. So you need to know the evolution of total body water, or TBW.
Okay, I know the general trend is downward as we age, but you want specifics.
Be precise. Start at the very beginning. The fetus.
Right. So in a fetus or a premature infant, the body is essentially a bag of water.
That's a good way to put it.
The TBW is extremely high. We're talking up to 80%, maybe even 85% of their total body weight.
Correct. Visually, I want you to think of a grape. Turgid, full of water. Now move on to the full-term neonate at birth.
It drops, but only slightly. It's around 75%, right?
Yes, 75% is the standard number to quote. So let's do the math right now. You have a 3-kilogram neonate. How much of that baby is water?
Okay, 75% of 3 kilograms is 3/4 of 3. That's 2.25 liters. So 2.25 kilograms, that baby is just water.
Good. Don't fumble the math. Now, what happens as they hit that 1-year mark, the infant stage?
It drops again. It's down to about 70%. And then by the time they are a school-age child or an adult, it finally settles into that standard 60% for males and a little less, 55% for females.
Okay, that's the easy part. Honestly, most students get that right. Here is where they fail. The distribution of that water. Talk to me about the extracellular fluid, the ECF, versus the intracellular fluid, the ICF.
This is the flip concept that Kaushik talks about in his review. It's critical. In adults like us, we have a 2-to-1 ratio favoring the inside of the cell. We have much more fluid inside our cells than outside.
Right, so in an adult, the ECF is about 20% of body weight. The ICF is double that, 40%, totaling our 60%. But what about the neonate?
It's flipped, or at least it's nearly equal. The neonate has this massive ECF compartment. It's nearly 40% of their total body weight.
Stop there. This is a critical why moment for the exam. The examiner will pounce on this. Why does that huge 40% ECF matter to an anesthesiologist? Don't just tell me the number. Tell me the implication.
Okay, there are two main implications. The first one is pharmacology.
Go on.
Water-soluble drugs, they distribute into the ECS. So since that bucket, the ECF, is relatively larger in a neonate, the concentration of the drug you inject gets diluted.
Give me a specific drug example, a common one.
Succinylcholine.
Nah.
Or mini antibiotics, like gentamicin. For these drugs, you often need a higher loading dose per kilogram in a neonate compared to an adult to get the same effect, to achieve the same plasma concentration.
Why?
Because the drug just keeps getting lost in that massive ECF ocean.
Exactly. It's a larger volume of distribution.
Good.
Yeah.
Now, what's the second implication?
It's about fluid balance and dehydration. That huge ECF is, it's labile. It's very easily lost.
What do you mean by lost? Where does it go?
They lose it through their skin, which is very thin. They lose it through their immature kidneys. And during surgery, they lose it through third spacing into the tissues. So a neonate can dehydrate much, much faster because a larger proportion of their total fluid is in a compartment that's, well, losable.
Perfect. That is the kind of distinction the examiner is listening for. Now, since we are looking at Kaushik Jathanath's review, he mentions some specific volumes related to the skull. This often comes up in neuroanesthesia vivas, but it's very relevant to fluid balance too. All right, I've got those noted down. The total skull volume is roughly 1,475 milliliters. The brain itself is about 1,300 milliliters. But the key fluid ones are CSF and blood. The CSF volume is only about 150 milliliters, and the blood volume in the brain is even less, roughly 110 milliliters.
Those numbers become absolutely critical when we talk about intracranial pressure and the risks of hyponatremia, which we'll get to. But let's park that for a second and stay on systemic fluids. We've established they are very wet and they have a huge ECF. Now, let's look at metabolic demand. Why do kids need so much water per hour per kilo?
Because the metabolic edges just run hot. They have a disproportionately high surface area to weight ratio.
Explain that to me. What does that mean in simple physical terms?
A child is small, obviously, but relative to their total weight, they have a massive amount of skin exposed to the world.
So they lose heat.
They lose heat incredibly rapidly. And to maintain their body temperature, they have to burn calories like a little furnace. A higher metabolic rate means more CO2 production, and it means more metabolic waste products, urea, creatinine, acids.
And how do they get rid of all that metabolic waste?
Through the kidneys, by making urine. But here's the catch, and this is another key physiological difference. Neonatal kidneys are immature.
How so?
Well, Miller points out that they cannot concentrate urine effectively until they're about a year old. They can't make that dark, concentrated urine that an adult makes when they're dehydrated. So to excrete the same amount of solute waste, they have to pee out a much larger volume of water.
Exactly. I've heard them called obligate polyuric. They have to pee a lot to clear their waste. They simply can't conserve water very well. And that brings us to the holy grail of calculations in this topic, the Holliday-Sigar formula.
A famous 4-2-1 rule.
Every student knows the rule. 4 milliliters per kilo for the first 10 kilos, 2 milliliters per kilo for the next 10, 1 milliliter per kilo for the rest. But if I'm your examiner and I ask you, where do those numbers actually come from? What are you going to say? Is it just magic?
No, it's not magic. It's based directly on caloric expenditure.
Yep.
The formula is actually derived from the observation that for every 1 kilocalorie the body burns, it needs about 1 milliliter of water for all the metabolic processes involved.
Good. Now break down the calories for me.
For the first 10 kilograms of body weight, A child burns roughly 100 kilocalories per kilo per day.
So 100 kilocal needs.
100 milliliters of water. And if you divide that 100 milliliter by 24 hours in a day, you get approximately 4.16 millimeters per hour, which we ran down to a clean 4.
Excellent. That is the distinction level answer. You're not just parroting a rule. You understand where it comes from. Now do the rest.
For the next 10 kilograms, the metabolic rate drops to 50 kilocalories per kilo per day, hence 2 milliliters per hour. And for any weight above 20 kilos, it drops again to about 20 kilocalories per kilo per day, hence 1 milliliter per hour.
Okay, demonstrate it. You have a 25 kilogram child coming for an appendectomy. Calculate their hourly maintenance fluid requirement. Do it out loud, clearly.
Okay, first 10 kilos. 10 times 4 equals 40 milliliters per hour.
Yeah.
Next 10 kilos, which takes us up to 20 kilos total. 10 times 2 equals 20 milliliters per hour. And the remaining 5 kilos. 5 times 1 equals 5 milliliters per hour.
So the total is?
Total maintenance is 40 plus 20 plus 5. That's 65 milliliters per hour.
Simple, fast, accurate. You cannot fumble that in the exam. It has to be automatic. Now let's move on. Part C, fluid therapy. We know how much to give. The next big and very controversial question is what to give.
This feels like one of the biggest shifts in pediatric anesthesia in the last couple of decades. The great war between hypotonic and isotonic fluids.
It was a war, and for good reason. For decades, the dogma was neonates can't handle sodium. If you give them salt, they'll become hypernatremic. So what did everyone use?
Hypotonic fluids. Dextrose and 1/5 normal saline. Dextrose and 1/4 normal saline, which is also known as Isolite P.
And Isolite P is still in a lot of hospital cupboards, isn't it?
It is, yeah.
And for most surgical cases, it should stay right there in the cupboard. Miller 10th edition is absolutely unequivocal about this. The old dogma was wrong, dangerously wrong, for the perioperative period. Why?
It all comes down to ADH. The stress of surgery, the pain, the nausea, all of it stimulates a massive release of antidiuretic hormone.
And what does ADH tell the kidney to do?
It tells the kidney to shut the gates, to hold onto free water at all costs.
Correct. So the child is physiologically primed to retain water. Now imagine you hook up a bag of Isolite P. That's a hypotonic fluid. It has very little salt and a whole lot of free water. You are pouring that free water into a bucket, the child, that already has a lid on it, which is the ADH. The water has nowhere to go. What happens to the blood?
It gets diluted. Serum sodium just drops like a stone.
Hyponatremia.
Acute hyponatremia.
Yes, and because of those skull volumes we discussed earlier, the brain has very limited space to swell. When the blood becomes dilute, water rushes into the brain cells to try and equalize the osmotic pressure. The brain swells.
Cerebral edema.
In an adult, you might just get a headache. In a child with a tight, non-compliant cranial vault, you get brainstem herniation, seizures, permanent neurological injury, death.
And it's terrifying because it's completely iatrogenic. It's something we, the anesthetists, cause by giving the traditional fluid.
Exactly. It's one of the biggest never events in our field. So for the exam, what is the standard of care today? What fluid do you choose?
Isotonic balanced salt solutions. Plasmolite is often considered the gold standard because its electrolyte profile almost perfectly mirrors plasma, and it has a favorable pH. Ringer's lactate is also perfectly acceptable and very widely used.
What about normal saline?
Normal saline is okay in a pinch, but if you give large volumes, it can cause a hyperchloremic metabolic acidosis, which we'd rather avoid.
Good. So if the examiner asks you, what maintenance fluid do you start for a 5-year-old getting a hernia repair, your answer is?
An isotonic balanced salt solution, like Plasmolite or Ringer's lactate. I will not say dextrose quarter saline.
But wait. The examiner is clever. They're going to counter with, but what about hypoglycemia? Children have very low glycogen stores. Aren't you worried they'll crash their sugar?
And that's a valid physiologic point, of course. But the thinking has changed. We don't treat the entire population for a risk that only affects a few.
Explain that.
Most healthy children who are undergoing routine surgery, they rarely get hypoglycemic if the modern fasting guidelines are followed correctly. However, neonates, infants, and any children with known metabolic disorders are at a very high risk.
So how do we manage that risk safely without causing the hyponatremia we're so scared of?
We can use what's called the 2-bag method, or more simply, we add dextrose to our isotonic fluid. You can take your bag of Plasmolite and add dextrose to make a 1% or maybe a 2% solution. Or, even better, you monitor.
Yes.
For a neonate or a long, complex case, you must monitor blood sugar intraoperatively. If it drops, you treat it. But you don't compromise the sodium safety of the main fluid just to provide sugar preemptively. You can give sugar and salt.
Perfect. Safety regarding the brain, the sodium takes precedence, and we manage the sugar concurrently. Great. Now let's structure the fluid plan for your written exam answer.
Yeah.
You mentioned I talked about the 3 buckets. Yes. If you get a 10-mark question on perioperative fluid management, do not just write a wall of text. Use headers, the 3 buckets. Bucket 1 is deficit, bucket 2 is maintenance, and bucket 3 is ongoing losses.
Okay, let's break down bucket 1, the deficit. This is the fluid they missed while they were fasting.
Right, and the calculation is simple. You take their hourly maintenance rate, which we already calculated using 421, and you multiply it by the number of hours they were fasting. So let's take our 25-kilogram kid from earlier. His maintenance was 65 milliliters per hour. Let's say he was NPO for 6 hours.
Okay, so the deficit is 65 times 6. That's 390 milliliters.
Good. And we don't just bolus that whole amount in at the start of the case, do we?
No, absolutely not. That would overload the heart. The standard teaching rule, and you have to write this down in the exam, is the 50-25-25 rule.
Break it down.
You replace 50% of that total deficit in the first hour of surgery. Then you replace 25% in the second hour and the final 25% in the third hour.
Good. Bucket 2 is the easy one. It's just the maintenance rate, our 65 milliliters per hour, running continuously in the background for the whole case.
Right. And bucket 3 is the tricky one. This is third space or surgical losses. This is fluid that isn't leaving the body in the suction bottle, but it's leaving the circulation. It's moving into the traumatized tissues, the bowel wall, the interstitium. How do we estimate this?
We can't measure it directly, so we grade it based on the degree of surgical tissue trauma.
Okay.
For mild trauma, think of a surface surgery like a hernia repair or an orchidopexy. You add 0 to maybe 2 millimeters per kilo per hour.
Minimal.
Minimal. For moderate trauma, like an open appendectomy, it's more like 2 to 4 milliliters per kilo per hour. And for severe trauma, think major abdominal surgery, like a bowel resection or a big scoliosis surgery, you're looking at 4 to 6 milliliters per kilo per hour, or sometimes even more.
Okay, so let's synthesize this. Our 25-kilogram kid is having an open appendectomy, so that's moderate trauma. He fasted for 6 hours. Let's calculate his total fluid rate for the first hour of surgery.
Do it.
All right. First, maintenance. That's 65 milliliter. Second, deficit replacement. We give 50% of the 390 milliliter deficit, so that's 195 milliliter.
Okay.
Third, surgical loss. For moderate trauma, let's pick 3 milliliters per kilo. So 3 times 25 is 75 milliliters.
And the total?
The total for hour 1 is 65 plus 195 plus 75. That equals 335 milliliters.
That is a significant volume. And if you hadn't done the calculation, you might just be running the fluid at the maintenance rate of 60 or 70 milliliters an hour, and the kid would come out of surgery hypovolemic and tachycardic.
Exactly. But, and this is the crucial examiner safe pivot you mentioned, these calculations are just a guess, right? They're a starting point. What's the real guide to fluid therapy?
You have to monitor the patient. You have to look at the child. What are you looking for?
Urine output is key. The goal is 1 to 2 milliliters per kilo per hour. Heart rate? Is it trending up? That's an early sign of hypovolemia. Capillary refill time. Is it brisk? Under 2 seconds. And blood pressure, of course, but you have to remember that in kids, significant hypotension is a very late and ominous sign.
Good. You can also look at things like fluid responsiveness, pulse pressure variation on the monitor if you have an art line. But the key sentence to write in your exam paper is what?
Fluid management is dynamic, not static. Calculations guide therapy, but physiological monitoring is the ultimate arbiter.
That shows maturity. That gets you marks. Okay, we've hydrated the child. Now let's move to the red stuff. Part D, blood management. This is where the math gets a bit scary for some people, but it's absolutely critical.
It really shouldn't be scary. It's just algebra at the end of the day. But first, you have to know your constants. The estimated blood volume, or EBV. I'm going to run down the list from Miller. Tell me if I get them right.
Go ahead. Drill yourself.
Premature neonate, 90 to 100 milliliters per kilo.
Correct. The highest.
Full-term neonate, 85 to 90 milliliters per kilo. Infant, so from about 3 months to a year, 80 milliliters per kilo.
Good.
Single-age child, 70 to 75 milliliters per kilo.
Right.
And finally, an adult, 65 to 70 milliliters per kilo.
Perfect. Now, why do we memorize these numbers so religiously? It's because of what I call the soda can reality. Let's take a 3-kilogram premature neonate. You said their EBV is up to 100 milliliters per kilo.
So their total blood volume is 300 milliliters.
300 milliliters. A standard can of Coke or Pepsi is 350 milliliters.
Wow. That visualization always hits hard. This entire baby has less blood in their body than a can of soda.
It puts everything into perspective, doesn't it? Now, imagine the surgeon is working. The suction is gurgling away. A few gauze swabs are soaked red. The surgeon turns to you and says, oh, minimal loss, maybe 50 milliliters.
In an adult, 50 milliliters, a rounding error.
It's nothing. But in this baby, 50 milliliters is 16% of their total blood volume. That's a class 1 approaching class 2 hemorrhage. If they lose 100 milliliters, that's 33% of their entire circulation. That is cardiac arrest territory.
So context is everything. You have to be watching that suction canister like a hawk. And speaking of watching, how do we actually estimate the loss? The textbooks always mention the gravimetric method.
Right, weighing the swabs. In a perfect world or in a research paper, yes, that's the gold standard. We weigh the bloody swab and we subtract the known dry weight. 1 gram of weight equals 1 milliliter of blood. But in a real busy OT or in your exam scenario, we use visual estimation.
But you have to be trained to do that properly.
You do. You need to know that a small 4x4 gauze, fully soaked, holds about 10 milliliters of blood. A medium Ratex swab holds maybe 10 to 20 milliliters. A large abdominal mop can easily soak up 100 milliliters. And you must always check the suction bottle. But what's the trap?
You have to remember to subtract any irrigation fluid the surgeon has used.
I have seen junior residents panic because the bottle has 500 milliliters in it, but they don't realize that 450 milliliters of that is just saline wash.
Okay, let's do the big one. The big calculation. The allowable blood loss, or ABL. The examiner hands me a piece of paper and a pencil. They say, calculate the ABL for a 10-kilogram infant with an initial hemoglobin of 12.
Walk me through it step by step. No rushing.
Okay, step 1, calculate the estimated blood volume. This is an infant, so I'll use 80 millimeters per kilo.
Yeah.
The weight is 10 kilos, so the total blood volume is 800 milliliters.
Step 2.
Step 2, determine the initial hematocrit, or high. The hemoglobin is 12. Hematocrit is roughly 3 times the hemoglobin, so the initial hematocrit is 36.
Okay. Step 3. This is the most important step. Determine the final allowed hematocrit, or HF. This is your transfusion trigger. This is where I, as the examiner, will stop you and ask, what number are you choosing for HF and why?
Right, this is the clinical judgment part. If the child is healthy, an ASA 1, I might accept a hematocrit dropping to 24-25, which corresponds to an HB of about 7 or 8.
Yeah.
But let's say this child isn't healthy. Let's say this child has cyanotic heart disease, like Tetralogy of Fallot.
An excellent complication to bring up. Why does that completely change the math?
For 2 reasons, really. First, they're often starting with a high hematocrit, polycythemia, just to compensate. But the main physiological reason is fetal hemoglobin, or HbF.
What about?
Neonates and some kids with cardiac disease have a lot of HbF, and HbF shifts the oxygen-hemoglobin dissociation curve to the left.
And left means love.
Right. The hemoglobin loves the oxygen, it binds it very tightly in the lungs, and then it refuses to release it to the tissues where it's needed. So to ensure the tissues get enough oxygen, you need a higher total mass of hemoglobin to overcome that high affinity.
Brilliant explanation. So for that cyanotic neonate, what would your trigger be?
My trigger, my HEF, might be 35 or even 40. I might not tolerate any significant blood loss without replacing it with packed cells. But for our healthy 10-kilogram infant, let's stick with an HF of 25.
Okay. Calculate the ABL.
The formula is ABL equals EBV times. Brackets, high minus HF, close brackets, all divided by the initial high.
Plug in the numbers.
ABL equals 800 times 36 minus 25, all divided by 36. So that's 800 times 11 divided by 36. 11 over 36 is a bit less than 1/3, about 0.3. So 800 times 0.3 is 240 milliliters.
So you can allow this infant to lose 240 milliliters blood before you transfuse. How do you replace that 240 milliliters as it's being lost?
So up to that ABL limit, I replace the loss with crystalloid, like plasmolite, at a 3-to-1 ratio. For every 100 milliliters of blood lost, I give 300 milliliters of crystalloid to try and maintain the intravascular volume.
Or call it at 1-to-1.
Or call it at a 1-to-1 ratio, though we tend to use that less now. Once the blood loss exceeds 240 milliliters, my ADL, I switch to blood.
Packed red blood cells, PRBCs. How do you give them? What's the dose?
We give them in small, measured aliquots. The standard dose is 10 to 15 milliliters per kilo. And the single most important safety point is what?
Tell me.
You must warm the blood.
Why? Why is that so non-negotiable?
Because a pediatric patient is a tiny thermal sink. If you pump 4 degrees Celsius blood from the fridge into a 3-kilogram baby, you will drop their core temperature instantly, and hypothermia leads to acidosis. And that combination, hypothermia plus acidosis, leads to coagulopathy. The clotting enzymes in the blood just stop working when it's cold and acidic.
And that's the triad of death.
The lethal triad. You can literally kill the baby just by not warming the blood you're giving them.
Absolutely critical. Fluid warmers are mandatory equipment. Now let's briefly touch on massive transfusion. If things are going badly and you find yourself replacing the child's entire blood volume, what's the main risk?
The main risk is dilutional coagulopathy. You're giving back red cells, but you aren't giving back platelets or the clotting factors. The blood becomes thin, and it just won't clot.
So what do we do?
We have to follow ratios. The trauma standard is now 1 to 1 to 1. 1 unit of RBCs, 1 unit of fresh frozen plasma, and 1 unit of platelets. In the OT, ideally we should be using TEG, thromboelastography, to guide our component therapy specifically.
Good. And other complications of transfusion, apart from the triad. Name 3 for the exam.
Okay, 3 big ones. 1, hypocalcemia. The citrate preservative in the blood bag chelates, it binds the baby's free calcium. And calcium is vital for cardiac contractility.
So the blood pressure drops.
The BP plummets. We have to be ready to give calcium gluconate. 2, hyperkalemia. Old blood cells lyse, and they release a lot of potassium. If you rapid push old blood, you can cause a cardiac arrest in diastole.
And the 3rd?
Tycho. Transfusion-associated circulatory overload, just giving too much, too fast, and overwhelming their little heart.
You're nailing the physiology. Okay, let's pivot. Let's switch gears to the other half of our topic title, Pediatric Daycare Anesthesia. This is an absolute favorite for a short note on the theory paper.
And it makes sense because it's such a huge and growing field. I think Miller says something like up to 60 or 70% of all pediatric surgeries are now done on an ambulatory daycare basis.
And it's great for the kids. I mean, there's less separation anxiety. They get to eat and drink in their own home. There's less risk of picking up hospital superbugs. But it puts a massive responsibility on the anesthetist to select the right patient. So if I ask you for patient selection criteria, what is the absolute #1 do not pass go exclusion criterion?
The ex-premature infant. If a child was born prematurely, let's say at 32 weeks gestation, and they are currently less than 60 weeks post-conceptual age, they are not a candidate for daycare surgery. Full stop.
Why 60 weeks? Why is that the magic number?
It's all about the maturity of the respiratory center in the brainstem. These infants are at a very high risk of postoperative apnea.
Meaning they just stop breathing.
Yes, they can just stop breathing hours after the anesthesia is completely worn off and they're home in their cot. They need, at a minimum, 24-hour overnight monitoring with an apnea alarm.
Correct. If you miss that in the Viva, it's an automatic fail. It's that serious. Now let's talk about the social factors. This is where the exam tests your real-world practicality. You're the consultant. A father brings his 4-year-old in for a hernia repair. The child is perfectly healthy, ASA1, but the father tells you, "Doctor, I came on my motorbike, we live 3 hours away in a village, and we don't have a mobile phone." Do you proceed with that case as daycare?
Absolutely not. That's either a cancellation and rebooking with proper arrangements, or it's an admission for overnight stay.
Wow.
Because the social criteria are just as important as the medical ones, and they are rigid. 1, you need a responsible adult escort, not just a driver. 2, you need appropriate transport, like a car or a taxi, not a motorbike or a public bus. 3, distance. They usually need to be within 1 hour of medical help. And 4, communication. They must have a working telephone to call the hospital if there's a problem.
Safety doesn't end when the patient leaves the hospital doors.
Exactly.
Let's talk about NPO, or fasting. The old starve them for midnight rule is dead.
Long dead, thankfully. It's the 2-4-6 rule now.
Tell me.
2 hours for clear fluids. It's water, pulp-free juice. 4 hours for breast milk. And 6 hours for everything else. Solids, formula milk, cow's milk.
And Miller goes a step further now. We don't just allow clear fluids up to 2 hours before. We actively encourage them. Why is that?
Because a hydrated child is a happy child.
It's true.
They cry less. They're less irritable. It's much easier to get an IV cannula in. And it significantly reduces the risk of hypotension on induction of anesthesia.
Okay, what about the anesthetic technique for a daycare case? The goal is to have them wake up bright, pain-free, and ready to go home.
So we have to avoid the hangover drugs. That means avoiding opioids, if at all possible.
Why avoid opioids?
Because opioids are the #1 cause of PONV postoperative nausea and vomiting. And PONV is the #1 reason for an unplanned hospital admission after daycare surgery. Instead, we rely on multimodal analgesia.
What does that involve?
It's a combination approach. 1, simple analgesics like paracetamol, given IV or rectally. 2, an NSAID like diclofenac or ketorolac, as long as there are no contraindications. And 3, the most important part, a regional block.
The regional block is the absolute superstar of daycare anesthesia. For a circumcision or a hernia repair, what block would you do?
A caudal epidural is fantastic. Or an ilioinguinal nerve block. It provides complete dense pain relief for 6 to 8 hours. The child wakes up totally pain-free, they can eat and drink, and they can go home comfortably.
And for the airway, we generally prefer a laryngeal mask airway, an LMA, over an endotracheal tube. It's less stimulating, causes less sore throat, and allows for a much smoother wake-up. Finally, discharge. When can they actually leave?
We use a scoring system, most commonly the PADS score, which stands for Post-Anesthetic Discharge Scoring System. They need to get a score of 9 or 10 to be considered for discharge.
What does that score measure?
It checks 5 things. Vital signs must be stable, no significant surgical bleeding, pain must be well controlled, nausea must be minimal or absent, and they should be able to ambulate or move around as appropriate for their age.
Now, the peeing rule is the controversial one here. Do they have to pass urine? Do they have to void before they can be discharged?
This has changed. The old school teaching was everyone must pee before they leave. The new school, and the evidence in Miller, says that voiding is only mandatory IF.
If what?
1, if the surgery was on the urinary tract itself, where there's a risk of a clot or obstruction, or 2, if a central neuraxial block like a spinal or a caudal was used, because that carries a risk of urinary retention.
So for simple finger surgery or an ENT case?
You don't need to wait 4 hours for them to pee if they are otherwise perfectly fine. But drinking is mandatory. They absolutely must be able to tolerate oral fluids without vomiting before they go.
Okay, we are in the home stretch now. Part F, integration and safety. Let's look at that classic clinical case that trips everyone up in the exams. Pyloric stenosis. This was a DNB question in December 2012. Concerns in hypertrophic pyloric stenosis.
Yes, this is the classic medical versus surgical emergency trap. The surgeon is standing there, ready to cut, and the anesthetist has to be the one to say, "Stop."
Why? Oh, what's the problem?
Because this child has been projectile vomiting stomach acid, hydrochloric acid for days or weeks. They're severely dehydrated, and they have a very specific, very dangerous metabolic derangement.
Name it.
It's a hypochloremic, hypokalemic metabolic alkalosis. The kidney tries to save volume by activating aldosterone, so it desperately dumps hydrogen ions and potassium ions into the urine in order to save sodium. This leads to something called paradoxical aciduria, where the urine is acidic despite the blood being severely alkaline.
So with that biochemistry, can you safely induce anesthesia?
Absolutely not. The high alkalinity shifts the oxygen curve way to the left, starving the tissues. The low potassium puts them at huge risk for cardiac arrhythmias, and the dehydration can cause cardiovascular collapse on induction.
So what's the takeaway?
Pyloric stenosis is a medical emergency first and a surgical problem second. We have to resuscitate and correct the biochemistry before going to the operating theater.
How do you correct it?
We rehydrate aggressively with normal saline, 0.9% sodium chloride to give them back the chloride they've lost. We add potassium to the fluids once we've confirmed they're producing urine. And we wait. We wait until the pH normalizes and the electrolytes are corrected. Then and only then do we go to theater.
And the induction itself, any special considerations?
The stomach is technically full because of the pyloric obstruction. So we have to suction the stomach with an OG tube before induction while they're awake, if possible. And then we perform a rapid sequence induction, or RSI, to protect the airway.
Perfect. Okay, one last deep dive thought for you before we wrap this up. Something that isn't in the basic text but really separates the top candidates. We talked about the blood volume of that tiny 3-kilogram baby, 300 milliliters. Now, think about the equipment we use. If you put a neonate on a cardiopulmonary bypass or CPB machine for open heart surgery, what is the volume of the tubing and the reservoir in that machine?
The priming volume of the circuit. Oh, it can be huge. It could be 200, 300 milliliters, sometimes even more, depending on the circuit.
Exactly. The machine's fluid volume is bigger than the baby's entire blood volume. The moment you connect that baby to the bypass machine, you are essentially diluting the baby's entire existence into the machine's prime fluid. You instantly dilute their platelets, their clotting factors, their albumin, everything, by 50% or more.
Wow.
And that is why neonatal cardiac anesthesia is the absolute pinnacle of fluid and blood management. For that period of time, you are managing a patient who is more prime fluid than they are blood.
Yes, that really blows my mind. It just highlights why that phrase, attention to detail, is the only thing that matters in this specialty.
It is. So let's summarize the exam strategy for everyone listening. My final advice.
Let's do it.
1. Know your physiology. You must know the TW evolution and the ECF versus ICF ratios cold. 2. Know your math. The 4-2-1 rule and the ABL formula have to be second nature. Show you're working in the exam.
3. Know your safety. Always choose isotonic fluids. Hyponatremia is the enemy. Always warm the blood. And always check the glucose in at-risk infants.
And 4. Know the socials. Daycare anesthesia is only safe if you have a reliable and safe home environment to discharge the patient to.
And if you do all of that,
Then you pass. And maybe, just maybe, you get to sit in the chair on this side of the Viva table one day.
thank you. I genuinely feel more ready to walk into that exam hall now.
You're welcome. And good luck to everyone out there who is sitting the Gujarat University MD exams.
See you in the OT.
See you in the OT.